Today's discussion is aimed at the basic entry level person in clinical medicine. It is not meant for the graduate or the postgraduate or the subspecialty, what we call in this region as super specialist. It's on the stethoscope. Everyone would have seen this stethoscope. It's a very simple instrument. The original version was invented by Laennec long back, but this is quite different from what was invented by Laennec in those days. What we have is a device, it's a spring-like device which helps it to fit into your ear, snugly fitting, and these are the tubes which take the signals to the ear. You have two earpieces. This will close the external auditory canal so that you will not hear much of the external sounds, only sounds conducted from the chest piece. This is known as the chest piece of the stethoscope, and this is the tubing which conducts the sound signals to your ear. And this is a very basic level of stethoscope. I would say it is only a diaphragm. It is a diaphragm over here, and the other side is dummy. There is no bell for the stethoscope. This simple type of stethoscope is meant for nurses mainly, for taking blood pressure. You know that while taking blood pressure by the auscultatory method, you have to hear for the correct cough sounds or the sounds heard over the brachial artery when you take blood pressure. As you release the pressure in the cuff, you will hear the sounds over the brachial artery if you keep it exactly over the brachial artery. For that, this diaphragm is useful. And in those cases, you don't need the bell. So this is a very simple type with only the diaphragm, functional diaphragm, and there is no bell. This one has both the diaphragm and a bell, and the bell has a padding, a rubber padding, so that it will fit on the chest wall without any gap, and this is the diaphragm. But mind you, while keeping this bell over the chest wall, you should not press it too much. If you press too much, the skin which is over here will act like a diaphragm. So the reception quality of the bell will change from that of a usual bell of the stethoscope to a diaphragm. So be careful that you don't press it too hard on the skin over the chest. You have to be just applying it lightly, but there should not be gap. If there is a gap, or sounds, the heart sounds will not be conducted well to your ear. And this is the diaphragm. You can choose which is the active one by turning it. You keep it fixed here and then turn it. You can turn it 360 degrees, and as you turn it, you will hear a clicking sound. When that clicking sound is heard, that means that particular one has been chosen, either the diaphragm or the bell, depending on what type of signals you are going to hear from the heart. This is what is seen inside the stethoscope. That is the diaphragm is not seen here. It is what is seen is inside, and this there is no padding here. It's an old one in which these two are lost. Now there are fancy stethoscopes like this also. You can see that there are two tubes taking auditory signals to the ear, and these tubes are thicker. Naturally, I would expect that this one will conduct the heart sounds and lung sounds better to the ear. And the difference in this one is the spring is external. In the other stethoscope, you have seen that the spring is within, while here the spring is external. And this one is quite heavy. The chest piece is quite heavy compared to the other stethoscopes. And these are the earpieces. Now, why do you need diaphragm and bell? That depends on the frequency of the sound you wish to hear from the heart or the lungs. higher frequency sounds will be better picked up by the diaphragm, while lower frequency sounds will be better picked up by the bell. You know that normal human voice, male voice is of a lower frequency and female voice is of a higher frequency. Some also refer to these as pitch of the sound. Similarly, for heart sounds also, there is a difference in frequency. First heart sound and second heart sound have a relatively higher frequency and are supposed to be better heard with the diaphragm of the stethoscope. While third heart sound and fourth heart sound, you would choose the bell to hear the sounds better. Of course, it is more difficult to hear third and fourth heart sounds, and they are not heard in physiological situations always, even though a fourth heart sound may be heard in older persons sometimes normally. But those are all very soft sounds, and you have to auscultate very keenly to hear third and fourth heart sounds. Third heart sounds also can be physiological in some conditions. In children, a third heart sound can be physiological, and in pregnant females also a third heart sound can be physiological. That is regarding the heart sounds. And murmurs are also having different pitch and frequency. That also will be picked up better with either the bell or stethoscope. For example, the mitral regurgitation murmur, it's a high pitched murmur which is better heard with the diaphragm. Aortic regurgitation murmur is also a high pitched murmur and will be better picked up with the diaphragm of the stethoscope. The classical example of a low pitched murmur which you hear with the bell of the stethoscope is the rough rumbling mid-diastolic murmur with pre-systolic accentuation of mitral stenosis. That is a murmur which is classically best heard with the bell of the stethoscope. For that, you are supposed to apply the bell. First, you have to localize the apex beat and apply the bell very carefully at the apex and then hear the murmur. You have to keep the bell just in touch with the skin without pressing. If you press, it becomes a diaphragm. For hearing the mitral stenosis murmur better, you can place the person in the left lateral position and breath may be kept in expiration, and you can sometimes use a coughing maneuver to hear the mitral stenosis murmur. That is, when you cough, the lungs are somewhat squeezed and the blood in the lungs are pushed into the left atrium through the pulmonary veins. So that increases the flow across the mitral wall. That can also increase the intensity of the mitral stenosis murmur, best heard with the bell of the stethoscope. Most localized type of murmur which will be heard mostly at the apex only if you place the stethoscope directly over the apex. Sometimes in persons with thin chest wall and also a loud murmur, you may be able to hear the mitral stenosis murmur easily, but very often mitral stenosis murmur is a little difficult to hear. Then tricuspid stenosis murmur is more difficult to hear. You have to go more medially, and still more difficult will be the functional mitral stenosis or the functional murmur in other conditions or flow murmur across the mitral wall, which is more difficult to hear, and most often the beginner in clinical medicine will not be able to hear functional mid-diastolic murmur at the apex or even in the tricuspid area in conditions like atrial septal defect. In conditions like atrial septal defect with large flow across the tricuspid wall, you would expect a functional murmur in the tricuspid area or the tricuspid MDM in atrial septal defect. Those are more difficult to hear than the usual classical rumbling mid-diastolic murmur of mitral stenosis. But all these are heard better with the bell of the stethoscope, and murmurs of VST will be better heard with the diaphragm. Basically, when the pressure difference between the two chambers, which is causing the murmur, is huge, you are likely to hear a high-pitched murmur. For example, in mitral regurgitation, the flow is from left ventricle to left atrium. The pressure in the left is much higher compared to the pressure in the left atrium. So you have a very high velocity jet, which is usually picked up as high pitch murmur with the diaphragm. And same is true of aortic regurgitation. The diastolic pressure in the aorta is in the range of 80 millimeters of mercury, while diastolic pressure in the left ventricle is below 10. So there is a large difference. But in case of mitral stenosis, the pressure difference is between the left ventricular diastolic pressure and the left atrial diastolic pressure. Left atrial diastolic pressure in mitral stenosis may be 25, and left ventricular diastolic pressure in mitral stenosis may be 5 to 6 or 8. So the range is lesser, and you naturally have a low-pitched murmur in mitral stenosis, while you have a high-pitched murmur in mitral regurgitation, aortic regurgitation. And there is a difference in case of tricuspid regurgitation. In tricuspid regurgitation, if the right ventricular pressures are high, as in pulmonary hypertension with the tricuspid regurgitation, the pitch of the murmur will be high, and it will be better heard with the diaphragm. Suppose it is a non-hypertensive TR. There are conditions which have low pressure tricuspid regurgitation. For example, when the tricuspid valve is abnormal, and as in Epstein's anomaly, it will be a low-pitched murmur. It may be better heard with the bell. So you have to know the physiology of the condition to decide on the frequency of the murmur and where the murmur will be heard, and which part of the stethoscope has to be used for hearing the murmur and interpreting it. And usually there is a clinical something which people say in jest when you are taught clinical medicine. They'll say that the most important part of a stethoscope is what lies between the earpieces. That is your brain, which is going to interpret the murmur. Unless you know the characteristics of the murmur which are expected in a particular case, it's very easy to miss a murmur. If you like my video, please give a thumbs up and subscribe as well.